this image of this patient, I think is stromal keratitis. But it's stromal keratitis composed a lot of things, a lot of causes. It's not only HFV, but other, for example, microsporia.
No. That's just a focus on this case.
Yes.
So, can you definitely diagnose with such size, say 5 times of recurrence for 3 years, and with sky vascularizations? Can you diagnose this is the episymptomatic keratitis?
For this patient is recurrent keratitis is first thing. The second one is the stromal keratitis. Is the subject and subject is only subject. The rest and HSV keratitis. But for definitely diagnose it's not possible because we have to do.
So that's enough. So you cannot definitely diagnose this is due to the episymptomatic keratitis. Am I right? Yes. So how about the second case? So what do you think? This is the typical dendritic answer, complete answer? I don't think so. How about Professor Dong, Dr. Dong?
So it's quite difficult to say because there's some other clinical picture. It's similar lines, especially for the normal corneal ulcer at the end of the stage, and you can see that. And in some patients who have endothelial decompensation, you also can see the picture like that. So typically, no, it's not typical. So if we see typically, we have to see the end of the dendritic. And the fluorescence can go under the epithelium. It looks like an oval shape. So typically.
So this is, I can say this is not typical dendritic corneal answer, except the pictures you show this in the journal presentations. Yeah, this is the typical. Yeah. Even it's not caused by only episymptomatic virus, but it's also caused by some others.
Yeah.
But we consider this is due to the episymptomatic. Yeah. That's why you didn't show the modern standard for diagnosis. It's very important. Say, if we can base on, you see, the clinical, you see, size. As well, what else? You still lacking one very important, see, factors or size. You don't have, say, the laboratory test. You didn't mention to the histology test as well as the DCI. Immune, not yet. So what you show up here, I don't think this is the definitely keratitis. You agree with me? Yeah. Say, because it's very important. Even episymptomatic keratitis now we saw not very not very often as like bacteria, but in fact sometimes confused and we are not able to diagnose. Even we just thinking, oh, this might be, but the golden standard we have already. The golden standard say if we have a typical clinical size, say dendritic, we have say pisiform and a little bit, some cases like a geographic corneal ulcer. we can diagnose. This is the herpes simplex. Some others, they also have the same dendritis, but they also combine with the general symptoms. For example, eruptions of the skin. But for herpes simplex, that's dendritis with also some eruption of the disc we get with or without. And for others, you also have, you see, the golden standards. The first one is the recurrent. In case it's not typical, say if the cognitive answers is not in dendritic, or say it's not in the geographic, we base on the first one is the recurrent. The second one is the sensation, decrease of the cognitive sensation. And the last one, sometimes we have to retry to treat the patients. And we base on some disease. And we also base on, for cognitive answer, we base on the laboratory tests with the giant cells and lymph nodes concept. And now we have the PCI. We can find. So I think that's very, very clear. But we, for quite a long time, especially young doctors, you're not, you see, focus on, you see, the clinic as well as the test. That the golden standard for, you see, diagnosing herpes simplex virus keratitis. The first one. And the second one, what do you think we can prevent the recurrence of the herpes keratitis? I don't know, you don't show the preventions.
No vaccination.
In case of the, you see, the disease, the recurrence, so what we can prevent the recurrence?
In the guidelines, they give this dose for the patient who have the history of stromal keratitis, but they not mention about the other patient who have epithelial or endothelial. I think maybe because the stromal keratitis is the main cause of the visual impairment of the patient with the neovascularization or the scar. And the dose they give to the patient is 400 milligram twice a day. There are studies, they give 200 milligram twice a day, and the time is for 6 months to 1 year. But there's no there's no duration. Studies show the duration of the dose. So I think it needs to be studied furthermore.
Yes. So I think to diagnose the herpes simplex keratitis is very difficult. It's very difficult. But easy with typical, you see, the size, like a dendritic, geographic, and also EC4. But the rest is very difficult because we cannot, you see, find exactly. Sometimes we just guess, and also we base on the criteria, you see, for diagnosing. As far as the, say, with the perforations, it's very important to indicate the cornea graft or not, because even in the graft, the recurrence can occur on the graft, and it may cause, you see, the failures of the surgery. And I just mentioned and focus on this topic because it's very important. Because the way of treatment quite different between, you see, the bacteria and also the herpes simplex. If we wrongly diagnose, we cannot, you see, reach to the success of treatment. And I think the first one This is to diagnose, you see, precisely the disease.
Okay, thank you much. Is there any other question or comment? Nobody have question. Okay, thank you very much, Dr. Hill, for your very good presentation. Have a good day, everybody.